Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 506 of our pharmacotherapy series, which majors in anemias. My next question to you reads: what preventive therapies exist for JYT that will reduce occurrences of vaso-occlusive crises? Hemoglobin F has a protective effect against hemoglobin polymerization. Investigators have observed that patients with hemoglobin F levels greater than 20% experience a relatively mild or benign course with fewer vaso-occlusive crises. Hydroxyurea has been found to increase hemoglobin F synthesis, which may decrease RBC sickling and the occurrence of disease-related complications. Hydroxyurea is used prophylactically in patients with recurrent moderate to severe vaso-occlusive crises but not in acute treatment. The use of hydroxyurea in the sickle cell population should be carefully weighed for risk versus benefit, because it is a cytotoxic agent associated with bone marrow suppression. The U.S. guidelines recommend hydroxyurea for adult patients who have 3 or more sickle cell-associated moderate to severe pain crises in a 12-month period. Patients taking hydroxyurea should have bone marrow studies performed before therapy and periodically during therapy. Other adverse effects of hydroxyurea include gastrointestinal effects, such as nausea, vomiting, and diarrhea, dermatologic effects, such as maculopapular rash, pruritus, and potential risk of developing a secondary neoplasm, that is leukemia, with prolonged use. The treatment dose of hydroxyurea for sickle cell anemia is 15 to 35 mg per kilogram per day. Goals of therapy include improvement in pain and well-being, increase in hemoglobin F, increased hemoglobin, if severely anemic, and maintenance of acceptable platelet and granulocyte counts. After initiation of therapy, blood counts should be monitored closely and the dose adjusted based on efficacy and tolerability. Several clinical trials evaluating hydroxyurea show improvement in the clinical course of patients with sickle cell anemia. Other areas of potential promise for the treatment of sickle cell anemia include bone marrow transplantation and gene therapy. Despite optimal treatment with hydroxyurea, JYT continues to experience exacerbations of his sickle cell disease requiring blood transfusions. JYT estimates he has required 6 such transfusions in the last 2 years and at least 25 units of blood in his lifetime. During a visit with his hematologist, JYT's serum ferritin is noted to be 1050 micrograms per liter. So my next question to you reads: what potential adverse effect of treatment is the hematologist's concern? What other tests may be performed to detect this? Patients requiring chronic transfusions of packed red blood cells are at an increased risk for iron toxicity due to iron overload. Normally, plasma iron binds with transferrin. However, if transferrin becomes saturated, patients will have higher levels of toxic non-transferrin-bound iron. As non-transferrin-bound iron increases, it deposits in other organs, most frequently the liver. Therefore, non-transferrin-bound iron produces free radicals, causing tissue damage and fibrosis. Patients with sickle cell disease should be monitored for iron overload. Obtaining a serum ferritin level is the most commonly used method of screening for iron overload, although the accuracy of this test is affected by inflammatory processes. Thus, serial serum ferritin values should be obtained when patients are not experiencing an acute crisis, i.e., steady-state values. More specific tests such as magnetic resonance imaging measure iron levels in organs such as the heart, liver, pancreas, and spleen, although may not be routinely used because of cost. The gold standard for assessing iron overload is liver iron concentration by biopsy, although this is an invasive procedure that should be performed by specialists. JYT returns for continued assessment of iron overload. His repeat serum ferritin levels are 1,357 micrograms per liter and 1,500 micrograms per liter, 3 months apart. Liver iron concentration is 7.8 milligrams per gram dry weight. So my next question to you reads: does JYT meet the criteria to receive iron chelation therapy? What options are available? JYT meets criteria for iron chelation therapy because of his steady-state serum ferritin levels being consistently more than 1,000 micrograms per liter and his liver iron concentration being greater than 7 milligrams per gram dry weight. Other considerations for a patient to receive iron chelation therapy include transfusion of approximately 100 milliliters per kilogram of packed red blood cells, or 20 units for a 40 kg or more patient. There are 3 iron chelators currently approved for use in patients with sickle cell disease. These agents work by binding free iron present in circulation and tissues. The iron is then excreted in the urine and bile. Deferoxamine is the oldest agent and has the most clinical experience. Deferoxamine and Deficiency have been studied in patients with sickle cell disease, who are as young as 2 years old. Deferoxamine is not approved for use in children. Because of its short half-life, deferoxamine must be administered daily via continuous IV or subcutaneous infusion for 5 days. Deficiency has a longer half-life, allowing for once-daily oral administration and enhanced patient convenience and adherence. A study of 195 patients with sickle cell disease observed similar reductions in iron levels between patients receiving deferoxamine and patients receiving Deficiency at comparable doses. Additionally, more patients in the Deficiency group reported their treatment was convenient. Deferoxamine has predominantly been studied in patients with transfusional iron overload with inadequate response to other iron chelating therapies, although it has been shown to be similar to Deficiency in patients with sickle cell anemia. Deferoxamine is associated with more dose-dependent oculotoxicity and audiotoxicity, although both agents may cause this. Deficiency has been associated with more nephrotoxicity, hepatotoxicity, and cytopenias. Either deferoxamine or Deficiency is appropriate for JYT at this time. . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . JYT should also receive appropriate monitoring consisting of serial serum ferritin levels and annual audiology and ophthalmology assessments. Some centers obtain a liver biopsy every 2 years during treatment to assess efficacy. Patients receiving Deficiency should have serum creatinine monitored weekly for the first month after initiation or a dose alteration and monthly thereafter. Monthly monitoring for proteinuria and assessment of liver function tests should also be initiated for patients receiving Deficiency. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Anaemias, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 507.